the last SBU webinar of the year, Your Health After 40. And SBU webinars are webinars for adults with spina bifida on topics identified by adults with spina bifida. Today, our panel includes Dr. Brad DiCiano, who's one of the medical directors for the Spina Bifida Association, and he's serving as the professional who knows about the health of people with spina bifida after 40. And our members of the community who are going to speak with you about their experiences about having spina bifida and being over 40 are Ms. Nancy Gore, who's a member of the board of directors for the Spina Bifida Association, and Dr. Tim Bry, also one of the medical directors for the Spina Bifida Association. So Brad.
Thank you, everybody, for joining us today. We really appreciate the nice turnout. And I think Juanita probably has some introductory statements about Q&As. We can insert the Q&As in the chat box.
Yes, thank you, Brad. You know, it's been a full year of using Zoom webinars, so by now you're probably used to it. But please, in your panel and your control panel for Zoom, you should be able to see the Q&A box. If you can't find it and you prefer to use chat, that's okay, we'll monitor both. But just think about your questions that you'd like to submit and please send them through the Q&A, and then at the end of the presentation, we'll make sure that we cover all of them. Thank you, Brad.
All right, thank you. So go ahead and get started. And I'm just going to frame the conversation, just talk a little bit about spina bifida in adulthood, what we know from some of the research, and then that'll sort of frame some of the conversation that goes after it. One thing I wanted to start with is to talk about spina bifida as a condition compared to the general population and compared to other neurologic conditions that are considered progressive. So I made these three diagrams. The one on the left shows just the general population. And generally, if you think of folks that are in the general population, they may have a decline in function just due to aging and medical complications that accumulate over a lifetime. So as they get heart conditions and arthritis and back pain and all these things, it can have an impact on your ability to function in a lot of ways. Compare that to the diagram on the right. So think about a neurologic condition. An example might be some types of multiple sclerosis where the condition is progressive. You start out as somebody in the general population, and then at some point in life, you develop the condition and you have progression. So as that condition gets worse neurologically, you may have a decline in function from those problems, but you will also have accumulated problems from aging on top of that. So people with MS get arthritis and other problems just like everybody else. Now, spina bifida is the middle diagram. And what I want to kind of demonstrate here is spina bifida is a congenital problem, so it affects you before birth. And so although it's not a progressive condition in the sense that spina bifida itself gets worse over time, like we would see in multiple sclerosis, for example, there can be complications from spina bifida that accumulate over a person's life. So that could mean that they have tethered cord, that could mean that they have orthopedic problems. And then on top of that, people with spina bifida also have normal aging just like everybody else. They have normal types of arthritis, they have heart problems, they have issues like we see in normal aging. So you can have a decline in function that's maybe a little more rapidly accelerated than what we would see in the general population. But spina bifida in and of itself isn't a progressive condition. Next slide. So a lot of people ask, why do adults with spina bifida get hospitalized? What are some of the common reasons? We know that when you're a child, you have lots of surgeries, and that may be a reason why you're hospitalized in a lot of cases. But in adults, we see some very common patterns. One of the top reason that people get hospitalized is for a urinary tract infection. And I have to say that some of these hospitalizations aren't really UTIs at all. People go to the emergency room and they get admitted because the doctors think that they have a urinary tract infection. It might be true, that might be what's going on, but sometimes people get misdiagnosed as a urinary tract infection because they catheterize, because they have bacteria in their urine, and they may be having a problem like a shunt issue. And shunt and catheter issues are also a top reason why a lot of adults are hospitalized. So catheters include things like bladder catheters, so people that have indwelling bladder catheters. And the third reason that we see that people get hospitalized is in the top three is wounds. So skin issues, especially from pressure, can be a big problem and reason for hospitalizations. And so what we see is that a lot of these things, like wounds and UTIs, can in some cases be prevented with good outpatient care. And we see these wounds and UTIs making up almost a third of the hospitalizations of adults. So our hope is that if we can do a better job with outpatient management of skin and bladder conditions, we can prevent some of those hospitalizations in adults. Not all, but some. And a lot of these preventable conditions are more common up to the age of about 51. I'll show you some data in a minute on some of the age breakdowns of reasons for hospitalization. And another important thing to point out is that some of these preventable conditions can be life-threatening. So infections that come from the skin or from the bladder can turn into sepsis, where the infection is throughout the whole body, and that can be serious. Next slide. So if you look at the reasons for hospitalization of adults with spina bifida and break it down by age, we see some interesting differences among different age groups. In the 18 to 35-year-old group, and also the age group up to age 50, the top three reasons for hospitalization are similar. So we see, like I mentioned before, UTIs, shunt and catheter issues, and wounds being very popular reasons for hospitalization in those groups. But when we get to age 51 to 64, the top three reasons are really very different. So we see them mostly related to back problems. So arthritis of the spine, degenerative discs in the back pain in general, which is a whole host of reasons, anything from tethered cord to non-spina bifida related problems. So we see pain and back issues very commonly in this middle group. And then in the 65 and older group, we see more medical conditions. So we see pneumonias, we see anemias, we see heart problems. And in the advanced age, in the 65 older group, we see stroke also being very common. And in those 75 and older, it's very common for people to be readmitted to the hospital again after they've been discharged. So 42% of people 75 and older with spina bifida who are admitted to the hospital will end up back in the hospital again within 30 days, sometimes because those problems aren't necessarily completely managed well and completely resolved. Next slide. And so a lot of people ask questions about how long do people with spina bifida live? And the most simple answer to that question is that we don't have good studies on this. We do know that people with the non-myelomeningocele types of spina bifida can live past their 80s. My oldest patient right now is 89, but these are people that were born before shunts existed. So these people do not typically need or have shunts. However, people with the myelomeningocele subtype have more complications, and they also have shunt issues. And we really don't know the life expectancy of people with myelomeningocele. Next slide. Here's a small amount of data from my own clinic. Some people ask, when people with spina bifida die, what are the reasons? And I brought this data to you just to show that in the majority of cases, both in people with myelomeningocele and non-myelomeningocele, the answer is we just don't know. we don't have a lot of information about why people pass away or what are the complications that they face, because it's not recorded appropriately. And although this was a small study, this is a pattern that we see even in the Spina Bifida registry, where we're just starting to understand some of the reasons for mortality. Next slide. So I just want to leave you with a few take-home points before we get into the discussion about aging with spina bifida. One thing to remember is that people with spina bifida age just like everybody else, but those aging effects can be accelerated. So some examples are that people might have joint problems from arthritis, they may have osteoporosis, and those can kind of take effect earlier in life than they would in other people. Another point is that people with spina bifida get complications from spina bifida itself, but they also get complications just like everybody else. So it's important to understand the difference between these two things, and that means it's important to have specialists who can tell the difference. So people with spina bifida who are aging generally need to see primary care physicians for those general issues, but also specialists who understand spina bifida specific complications. So a good example would be, someone who is an adult with spina bifida who's having back pain. The back pain could be from a spina bifida complication like tethered cord, but the back pain could be spinal stenosis, which is an arthritis type degenerative condition that can affect anybody, people who don't have spina bifida. And finally, my third take-home point is that taking good care of yourself can prevent some of those long-term problems. Remember that some of these preventable conditions that land people in the hospital and can cause cumulative problems with aging may be preventable with good self-management, good measures in taking care of your skin and your bladder. So thank you very much for joining us today, and I'll pass it off to Nancy.
Hi, everybody. I'm excited to be here. I am 62 years old. I have a myelomeningocele. When I was younger, I used braces and crutches. But when I moved out on my own and started working, I found that using a wheelchair was a lot easier. So I've used a wheelchair really since I was around 21 years old. I've never had a shunt. And in terms of my life outside of this, I am retired. My husband jokes I'm retired for the third time. My first job was a career with Bell South, now AT&T. I worked there for 26 years in mid-management. Took early retirement at 49, went back to school, got my master's in teaching, and then taught for 10 years. So I've been retired now for a little bit over a year. And I want to talk about two different aspects of aging, the physical aspect and the social aspect. So in terms of the physical aspect, for me, I think one of the most important things is weight management. While I recognize I am still somewhat overweight, managing my weight has been important ever since I was a little girl. My parents always emphasized that. They watched what I ate, taught me to watch what I eat. So even today, I really pay attention to keeping my carbs low, keeping my sugar low. I never eat more than 2 meals a day. And exercise has always been a part of my life. Again, when I was a little girl, my mom always pressed my sister and I, don't sit there and watch TV, go out and play. So we'd get on the swing set and I had a little thing that was like a bike, but I moved it with my arms. So I was outside all the time. I loved swimming, and all of that stuck with me as an adult. Once I got into college, a friend of mine turned me on to weightlifting, which I still do today. I'm into kayaking. I've enjoyed scuba diving. So moving and doing things has always been a big part of my life. When I was 35, I was having problems with accidents, and I decided to get a colostomy because accidents at work are not fun. And that really, I think, has helped me from a health perspective as well. One of the things that I learned as recently as a year ago was I was having some problems with, sorry, my dog's making a racket in the background, with constipation. And my doctor told me about something called MagCalm. And that's helped me keep regular for the past year. When I was in the 3rd grade, my mom was worried that me dealing with diapers was not cool. And so we decided to have me get an ileoconduit that, again, once I was in the working world and experiencing leaking, I went in for a revision, and I now catheterize through my belly button. And in terms of making sure that that's all well and good, is I make sure that I keep that clean and irrigated, and that has kept down infections. I very rarely get a UTI, in fact. So in addition to that is pressure sore management. This I am certainly not a subject matter expert on. I had my first pressure sore when I first started using a wheelchair because I didn't know what the heck I was doing and I had a stupid cushion. Then I didn't get another pressure sore until about 10 or 15 years after that was due to some complications from surgery. I went almost 28 years without a pressure sore until last year. So, and I really think that the one I got last year was a result of sitting too long when we made a trip out west that took, a week-long trip. So pressure sore management, as we saw in the slide that the doctor just showed us, is really, really important. And I've done a few things to be more diligent about watching that and making sure that I don't get another one. The other thing that I noticed growing older that has been a challenge is taking care of my shoulders. As I mentioned earlier, I've been weightlifting since college, and I wasn't doing my shoulders any favor. I was probably using way too much weights. I used to wheel around Stone Mountain for exercise. I've been boxing. So I have really done a number on my shoulders. So back about 10 years ago, I started to have problems with my rotator cuff. I also found out that I have arthritis in my shoulders. So I take better care of my shoulders now. Two of the things that I do to help take better care of my shoulders, one is I don't wheel up hills and through gravel anymore. I got one of these things that's called give me just a second, a free wheel, which my husband fondly refers to as my big wheel, because that's exactly what it looks like. It raises my two front wheels up with a bigger wheel out front. That way I don't have to struggle to get through gravel or sand or whenever I'm off-road. It makes it a lot easier. The other thing that I did is I got through insurance something called a smart drive, so that when I know I'm going to be in an area that's got hills, I just throw that on the back of my chair, and it's a little motor that pushes me uphill. It's been pretty awesome. So both of those things really have been helping me keep my shoulders in much better shape. On an ongoing basis, in terms of what doctors I see, I have a primary care, a gynecologist, a urologist, and a gastroenterologist. And I actually have never really worked hard at trying to find a doctor who is well-versed in spina bifida, because as we've always known, it's referred to as a snowflake disease. So everybody, or a snowflake situation, not a disease, and everybody's different. So I've always considered it my job to inform the doctors as to what my specific issues are, what surgeries I've had, and what my conditions are. So that's always been as my parents taught me, it's always been my job to manage that. Plus, I'm lucky. I live in Atlanta. We have great doctors here. They're, you know, I don't have to go far to get to a doctor, unlike a lot of people out there. And because I've always lived in the Atlanta area, I've been able to find doctors that are all in the same hospital group, which has been important because they can talk to each other. They can email each other. And that's come in handy a number of times. So in terms of social, because I think I'm running out of time, you know, I've really, when I was working, I always worked between, definitely over 40 hours of work, hours a week, usually around 50. But after work, I would always make a point of going to the gym, going out with friends. I loved taking adult ed classes. I still all do all of those things today, well, pre-COVID. But I've also gotten very involved in my church. I'm on our church council. I teach Sunday school. I'm on the SBA board. I take a writing class. So all of those things keep me involved socially, which I think is really, really important. I've been married for 25 years, and my husband and I travel a lot, and we have a travel trailer. And with that, we travel with a group that all have this similar travel trailer. So that's another way I really enjoy having an active social life. So if I went over, I'm sorry.
No, not at all. Thank you so much, Nancy. I am going to stop for just a second before we move on to Dr. Bry, because there are two questions specifically for you.
Okay.
First one was, why did you decide to revise the ileal conduit? Sorry.
It leaked all the time. And this was back in the, it would have been in 1990 that I had that revision done. And so back then, what I was using to keep a bag on had cement and it didn't stick well. And I was leaking constantly. So I just got over it. And a friend of mine had a similar surgery done for a revision and had a great experience with it. And so, so that's why. And it definitely, you know, nothing is perfect. I still will leak occasionally. I usually find that if I'm leaking, it's one of two reasons. Either I've gained weight or I have gotten constipated. And once I fix those two issues, I'm usually fine. So it was, for me, it was the right choice to get that revision done.
Thank you. And there was a question about the name of the product that you mentioned, Magcalm. How do you spell that?
Magcalm. And it's a powder. You get it at, I get it at CVS. And you put it in hot water, and I get it unflavored. And as I said, it works like a charm. I tried literally just about everything on the market, and it's the only thing that's worked for me.
And we have one more question, and if you feel that this would be a longer answer, we can always address it a little bit later on. But I'll just give you the question. It was, is your travel trailer accessible, and how did it get that way? Can you give any hints on how to get one?
I have an Airstream, and my husband is brilliant and a machinist by trade, so he can build and fix anything. So he has made it accessible by doing a variety of different things. And I do not use my wheelchair when I'm in the trailer. I'll scoot around on the floor, I'll pull myself up on the chairs or pull myself up on the bed. And to be honest, while it works great for us, because Mike is able-bodied, he winds up doing all the work when we're in the trailer because I don't have my wheelchair in there. So it really is a huge gift that he gives me when we go traveling. He does it all.
Right. Thank you so much. All right, so let's move forward then with Dr. Bride, please.
Hello, everyone. I am glad to see such a great number of people who are interested in this. And so although I am a physician, I am not coming at this from a professional expertise totally, because I'm a pediatrician by training, so I know nothing anymore about adult onset problems. So this becoming older has been a learning experience for me. I understand spina bifida, but I don't understand adult issues, so I've had to rely on other physicians and people that I work with. By comment, I would first want to say that I agree with Nancy. I have found over the years that I just have to do a lot of educating of the physicians I see related to spina bifida. They will have heard of it, but there's a lot they don't know. I have been fortunate in that some of the issues, things like wounds, have not been something which I have experienced greatly. I watch my skin pretty carefully, and so I have been fortunate about that to date. I do catheterize. I do have a bowel program that I do, and unlike Nancy, at this point in my life, I'm single. So I've had to kind of figure out life and career and getting things done around the house when it's me, myself, and I. I am fortunate that obviously I'm in a profession where I can afford to get help if I need help, but I also have a good set of friends and neighbors that do things for me. I also do not have a shunt, and so I've been fortunate in that regard. And I also walked independently and in the community into my adulthood. I did find that when I was in my medical career and needed to walk the hospital and multiple corridors and get from one place to another at times quickly, that was fatiguing for me. And so I switched actually not to a wheelchair, but to an electric scooter that for years I just kept at the hospital. I didn't use it when I was at home. I didn't use it in the community if I was grocery shopping or doing other things. As I've gotten older, I have had issues with arthritis, particularly knee pain at this stage. I'm 64, by the way, soon to turn 65 in 2021. And so I have found that I've had to use my scooter more than I did. And so I do use it at times at home now, or if I'm in my community at some of the local shops, and obviously at work. So that has kind of been my solution to mobility. I do want to say that I think that for me, the mobility issues with aging are something that has been more gradual. And I think that is one thing that we have to think about as we get older in working with our physicians, is how fast is your body changing? Aging affects generally take time unless you develop an acute problem like spinal stenosis. It's giving you more acute symptoms. So, changing in mobility is going to happen because we don't have full muscle strength, but even in everybody who does have full muscle strength in the legs, muscle strength goes down over time with aging. And so I think being aware of your body and how fast things are changing and evolving may be an important thing for us to think about as we get older. Although I have not had major issues with pressure sores or wounds during my life, I've had a couple that were more minor. And frankly, due to stupidity. I do worry that another body system that changes related to aging is just the elasticity of the skin and the texture of the skin. And I do wonder, as people my age and younger in greater numbers age, I will be interested in kind of monitoring what happens with wounds in terms of it not just being clustered in younger ages, but what happens when we age. And I do think it's important to watch that. I will also tell you that I am not as good as Nancy at exercise or doing some of those things. So I am now dealing with some of the secondary consequences of that in terms of needing to see a cardiologist and other kinds of specialists that relate to disorders that are common in adults. While I did a pretty good job when I was more ambulatory over the last 5 years, it's become increasingly important to watch what I eat, how much I eat, and to try to get exercise. Because again, metabolism changes as you get older, and so the tendency to gain weight affects everybody as they get older. What else can I tell you? I will say, again, I've been very fortunate because I have an older brother who lives closer to my parents. I currently live in Seattle. My mother lives in Nebraska. But I do worry also not just about healthcare, our healthcare as we age, but some of the effects of what happens within family units and our own mental health. Nancy certainly touched on the mental health piece, and I think it's easier to become more socially isolated when we're older, and it's harder to go out or to do things. And I think that's a major concern that I have for those of us who are aging. But I also worry about the aspects of the interaction of the family. As we get older, you know, I've had to do more work in helping to take care of my parents, but I also wonder, in my role as medical director of the Spina Bifida Association, what happens when parents are still helping their adult children and then the parents are aging and not able to provide the same support, and what might happen to healthcare or to other psychosocial aspects with that. And I obviously don't have an answer to that, but it is something that I think as a community we need to think about and be aware of. I guess finally, I would say that it's important for us adults to know our bodies and to understand our spina bifida and what we need. I'm in my 60s. Spina bifida clinics didn't exist when I was born. And I don't expect that the people that I'm seeing in the adult world are going to know that much about it. SBA is currently working really hard on trying to continue to build resources for adults for their health care, but that's a problem that we're going to have to all fight for and advocate for. So I think it's important to understand your body, what's different, what's changing, what's not changing, and being open to that. For my major care, I do have a really good primary care provider, and then I see an adult urologist who's experienced with bladder management happening to children and adolescents with spina bifida. So my provider happens to be experienced understanding augmented bladders and catheterizations and what to watch for, et cetera, et cetera. So I'm fortunate in that regard. And I'm open to any questions.
Well, thank you so much, Tim. Thank you so much, Nancy. We have a number of questions. Before we get into them, a few people have asked about some of what you just touched on, which is in terms of finding care for adults. And so one person said that finding multidisciplinary teams for those of us with spina bifida is challenging. Many practitioners see spina bifida as a childhood issue and do not have familiarity with treating adults with spina bifida. There are very few multidisciplinary clinics for adults with spina bifida. Do we see this changing in the future, and what can be done to develop more clinics for adults with spina bifida? And this is something you touched on already, but if you have anything else to add.
Brad, I don't know if you want to start with that or if you want me to have my own comments about it as a physician and SBA medical director.
Sure, relay your own comments and then I'll add to it. I have a couple.
Okay. The short answer is it's a real challenge. And I do not expect that one-stop shopping multidisciplinary clinics for adults are going to develop rapidly around the country. Adult healthcare in general is predicated that you as the adult are responsible for helping to decide what you need and seeking, along with referrals from primary care doctors, seeking those referrals individually. So I don't go to an adult multidisciplinary clinic where I have an adult primary provider and the urologist. I have to keep track of my appointments on my own. And I think in the short term, that's going to be the case. In terms of adult providers, we are at the Spina Bifida Association, we are actively trying to develop resources and names of adult providers that we hear of who have some experience. I think always a good provider to see is somebody in a department of physical medicine and rehabilitation, a rehab medicine doctor like Brad is, because while spina bifida is different than spinal cord injury that's acquired, there's a lot of overlap in terms of a lot of the needs and challenges with bladder and bowel, and challenges with back pain and sorting out what might be causes of back pain. So in the short term, I certainly think that having a physical medicine and rehabilitation doctor that you can go see is important. Depending on the area of the country, there are also what are termed med-peds physicians who are primary care doctors usually. But med-peds physicians are boarded both in general pediatrics and in general adult internal medicine. And while they may not have great experience in terms of spina bifida itself, they are experienced with a lot of chronic conditions that are seen in childhood because they will have gotten some training in their pediatric training. And they're very familiar with conditions of adulthood as internal medicine people. So if you have the opportunity to find a med-peds doc as a primary care doctor, I think that's good. Some med-peds doctors are developing chronic disease, including spina bifida clinics at major medical centers so that they can take care of adults with more complex kinds of issues. That's a field which is evolving and developing, but I agree it's a challenge now. And I think the challenge is in part that we are trained in the pediatric world that multidisciplinary clinics exist because approximately 120 pediatric multidisciplinary clinics exist. And that may exist in the adult world in at best probably 15 to 20 places that have some experience routinely seeing adults in a coordinated fashion. So I think the onus is going to be on us in the short term to know who we need to see and be able to keep track of those appointments. I'm sorry that was a long answer.
Yeah, that's exactly what I was going to say. I think, this is an issue that's brought to SBA by a lot of people. We hear this voice from many people who express this as a concern, and that's why at SBA we've developed some initiatives where we want to increase the capacity of people throughout the country that are experienced and trained and willing to see adults with spina bifida. And so we're looking at ways that we can target developing a better network of rehab doctors like myself, med-peds doctors, and others who can address these problems, especially in places where there aren't clinics for people to go to.
Thank you. And just one last thing too, in terms of the National Resource Center of the Spina Bifida Association, in the Q&A, and also at the end of the presentation, you'll see my email address. Certainly we're happy to help you find providers in your area or as close to your area as possible. So now we have a lot of questions. And the first one is, in terms of assistance with moving the bowels, for example, surgical, what would you consider to be the most successful option for adults trying to maintain bowel control?
Well, for me, as I said earlier, I was 35 before I opted for a colostomy. And at the time, it was an emotional decision too, because I had just gotten rid of the bag for my urine, and now I was taking on a bag for my poop. But the problem of accidents far outweighed the concern of the bag. And once I got the colostomy, it improved my life immeasurably of no longer really having to worry about accidents. And could be just luck, but ever since I've had it, since I was 35, I have never had an accident at work or at school. It's been great for me. I know that's not necessarily for everybody, but it's helped me manage my bowels far more easily than it was before.
We can move on to the next question. It says, oh, go ahead.
Juanita, can can I answer that as well?
Please.
I've not had surgery for my bowels, but I think one of the things that we hope in the future is that the ACE procedure, MACE procedure, or antegrade colonic enema, which is ACE, or even the Peristeen using a non-surgical device to do a large volume evacuation of the colon is something that will be available in the adult world more. There are probably not a lot of adult surgeons who know how to do an ACE, but certainly pediatric surgeons and urologists do. But we're hoping that we won't have to necessarily use ileostomies or colostomies as much in the future as was done in my generation of times. The ACE procedure and bladder augmentation procedures really did not come into practice until the 1990s. So it was a relatively new thing, or just evolving when Nancy chose to have her colostomy.
You know, and if I can jump in too for what, to add to what Tim just said, because the ACE procedure, I might be calling it the wrong thing. I mean, none of that was available when I was growing up. And so I really didn't have any, I wasn't aware of any other options. So it was accidents or colostomy. Those were my choices. So that's that.
Very good. All right, thank you. Here's the next question. I was born with spina bifida 65 years ago. This year, I was diagnosed with Parkinson's disease. Is there information available on these two conditions coexisting? So far, management of both is proving difficult.
I'll try to take this one. This was actually a question that we received once recently. And in my experience, I don't have a lot of patients that have both conditions simultaneously. So I did look at the literature. I think that it's relatively uncommon. I think, though, that as we see people with spina bifida aging, we're going to start seeing more problems occurring in this population, just like we see in the general population. So I think what makes it complex to manage these both of these conditions together is the effects that they both can have on your function. So what I would recommend for someone who has an additional condition like this is to make sure that you have a specialist that can take care of you for your spina bifida, but also can address the types of issues that you're having with Parkinson's. And typically for Parkinson's, you would want to see a neurologist.
Thank you. Shall we move on to the next question? All right. What is the connection between spina bifida and respiratory problems?
I can take that one as well. So I would say there's three connections. The first is that some people with particularly myelomeningocele can have a Chiari malformation. And that's a way that your brain is shaped in the back of your skull that can affect the way that your brain controls your breathing. So some people can have apnea, which happens especially at night when you're trying to breathe during sleep. Some people also have obstructive sleep apnea, which is due to obesity. And a third reason is that some people have restrictive lung disease, which means that you have curvature or scoliosis of your spine, and it really affects the way that your lungs can expand while you breathe. So if the lungs can't expand throughout your whole rib cage, sometimes you can be at risk of complications like pneumonia, for example.
Thank you. Dr. Bryce, anything that you would like to add about that?
No.
Okay. All right. So our next question then is, can you talk about pelvic floor collapse after menopause?
I'll take that one. So actually, we do have a section on this in our women's health guidelines. So remember, our guidelines for the care of people with spina bifida are available online and in our app. In the women's health section, there is some information about pelvic organ prolapse. This happens, we know, most especially in women that have weak muscles and also in women that have reduced sensation in that area. And one of the recommendations that we have for people dealing with this is to have a specialist who is a urogynecologist. This is a very special type of training where a urologist can get dual training in gynecology. And these experts are specially trained to deal with this type of issue.
And actually, there's a related question on the guidelines. And it's about regarding guidelines for the care for people with spina bifida in terms of exercise. And the recommendation is for adults over 18. So does the recommendation change for people after a certain age? Because this question was specifically about exercise.
What I can do with that question is I will, the recommendations can also be found in our guidelines in terms of how many minutes and hours per week people are recommended to exercise. So I posted a comment for the 18 and up group for adults, but I will post a really specific comment to that one in particular, using some of the information that's in the guidelines.
Sorry, had trouble unmuting myself. Thank you. So the next question is, I had bladder cancer twice after 50. I don't smoke. Is that common as we age? I'm 67 now with MMC.
I would be interested to know if this person has any history of bladder surgery, particularly an augmentation, or if they have any type of indwelling catheter, because we do find that some people that have a catheter that's permanently indwelling, like a suprapubic catheter, or some people that have had an augmentation, sometimes can be at a slightly higher risk of bladder cancer issues. And so if you have either of those procedures, we usually recommend that you have a urologist and that you talk to the urologist about whether you may need any type of scope to take a look at the bladder on a kind of a regular basis.
Okay, thank you. I'm going to go ahead and ask a couple of questions that were submitted in advance. And the question is about the prevalence of neuropathy in the lower legs and feet among adults with spina bifida. I am 73, and until the last 10 years or so have walked normally. Now with the neuropathy in the feet and growing leg weakness, I'm subject to falls and have started wearing a leg brace. I also use a cane. Additionally, I had breast cancer and chemotherapy 20 years ago. Is that a bigger factor than spina bifida in my neuropathy?
I'm going to take that one as well. So when we say neuropathy, what we typically mean is that you're having a problems with the nerves outside of the spinal cord. So there's hundreds and hundreds of reasons why people can have neuropathy. A common reason that a lot of people have neuropathy is diabetes. Another reason that people can have neuropathy are medications like chemotherapy. So that could certainly be a reason for your neuropathy. Sometimes people use that term a little bit more loosely just to mean that they're having numbness or tingling or weakness in their legs. Sometimes those problems can be coming from spina bifida related problems, particularly things like tethered cord. So it would be really important to have a specialist who can find out what is really causing this problem. So it could be coming from your back, for example, or it could be coming from the nerves, and there's testing that can be done to help figure that out. So I would recommend seeing perhaps either a rehab doctor or a neurosurgeon to help get answers to that question.
Thank you. Next question then is, do we experience cognitive decline earlier than the general population? And I'm so sorry to interrupt. Before you answer that, just wanted to do a quick time check. We're at about 4 minutes before the end time. But it's up to you if you would like to keep going a bit more to answer the questions. We have about 8 or so more to go.
Go ahead, Brad.
So as far as cognitive decline, that's a little complicated because people who have spina bifida who are living longer can certainly get cognitive decline just like any other older adult. But there also could be reasons that are spina bifida related why somebody could have cognitive decline. One of those reasons could be if it's a problem with the shunt, for example. Another reason is that there are medications that people take, particularly some of the bladder medicines or some other medications that may cause confusion or cognitive issues. So it would be important to see a specialist who can help tease that out. Look at your medications and also take a look at any spina bifida related issues that could be causing this problem.
We have a question about shunts. I've heard that individuals with myelomeningocele can have shunts placed, but then over time, the shunts might stop working and the individual might then be able to function without needing to have their current non-working shunt revised. Would this positively impact the lifespan or have no impact at all, despite the individual having an MMC diagnosis?
I will try to address this one. We do know that there are adults out there who have had shunts placed where the shunts are not working, or at least not working optimally. I would say that most of the neurosurgeons that I have interacted with are actually concerned about the thought of taking out a shunt, even if it's not working, because the tract for the shunt tubing where it drains may still be able to shunt some fluid away, and we're not sure that the idea of shunt independence is accurate or not. I think that's an area that we still need much more study on. And Brad, I don't know if you have additional comment.
No, I agree with everything you said.
Thank you. Okay. So what type of research is being done about Chiari and Ehlers-Danlos comorbidities to spina bifida? I have about 6 of them, and my doctors and neurosurgeon feel that they are all connected somehow.
So Chiari malformations we know are particularly common in people who have myelomeningocele subtype. So there is research out there that looks at what are some of the complications that you can get when you have a Chiari malformation. That's part of the information that we collect in the Spina Bifida registry, for example. As far as Ehlers-Danlos, just like conditions like Parkinson's disease, these are other conditions that affect the general population, and when they affect people with spina bifida as well, we don't typically have a lot of research in those areas because we don't have a lot of people that have both of those conditions to have enough studies to really look at that. So I haven't seen really too much research on the combination of Ehlers-Danlos and spina bifida specifically.
Thank you. And actually, we had another shunt related question. I had a shunt from age 5 to 12 or 13 years of age. I'm now 40. What are the chances I'll need another shunt? I've had a mild case of hydrocephalus since I had my shunt taken out by emergency surgery many years ago.
So I would say that's hard to say. It may really depend on your individual situation and what symptoms you're having. That would really be a good question for a neurosurgeon. So if you are having complications from your shunt, I would recommend, talking to your neurosurgeon about whether that's something that needs to be followed, what frequency of visits you have to have checkups to see what's going on. And also it would be good to make sure that you have eye exams because that's another way that we can detect problems with the shunt.
Thank you. And here's another question about physical therapy. And what type of physical therapy do you suggest for people with spina bifida? Is it all individualized, or are there some that are specific to spina bifida?
I have not had, the only time I've had physical therapy has been with my shoulder. But outside of that, my workout routine, I have gotten from a variety of different sources, one of which was the physical therapy on my shoulder and what to do long-term to keep my shoulders healthy. But outside of that, I've used coaches at the gym who are well-versed on building upper body strength, not well-versed on spina bifida, but my obviously emphasis as I'm working out is keeping my upper body strong. So I guess I'm saying I can't really answer that question except to say that I think there's a lot we can do on our own through the internet with learning about how to get the best exercise and the best types of exercises to do for our own bodies. I think that's been really helpful for me, is being able to having those resources available to have the best possible workout. And I don't just lift weights. I also use a hand bike at the gym to help keep me fit aerobically.
I would just add that for physical therapy that is prescribed by a physician, the best physical therapy prescription is customized not only to you as an individual, but also to the type of problem that you're having. So as a rehab doctor, we're trained to really tailor the prescription for your physical therapy to the type of problem you're having. Oftentimes, patients will come back and they'll say, well, physical therapy didn't work for me. And then I ask, well, what did the physical therapist do? And we find out that, they weren't using treatments or exercises that really would help with that problem. So it wouldn't be a surprise that it didn't work. So if you were going for physical therapy that's being done through a prescription, you want to make sure that the person prescribing it is addressing your problem. And physical therapists themselves are oftentimes very good at assessing what's going on, and sometimes will be able to pick up something that the physician didn't and be able to modify the treatment plan.
I would like to briefly comment and say that I think of physical therapy differently than I think of exercise. To me, physical therapy is not exercise. And if you're wanting resources on activities you might be able to do, they still to some degree have to be individualized, but if you know your body and what your body's capable of, the National Center for Health, Physical Activity and Disability is a really good resource and has a number of resources on exercise for people with disabilities and options for that.
And if you're looking for exercises, et cetera, the organization that Dr. Bride just mentioned, if you go to our website and look under SBU or our YouTube channel, we have a webinar about being physically active, and all of those resources are mentioned there. So, Dr. Bride, I know that you need to get going. So should we, and now we do have a few more questions left. So Nancy and Dr. DeCiano, if you need to get going, just let us know. We respect that. And we can address the questions possibly by email later on. It's up to you.
Yeah, I think we do have another meeting coming up. So what we can do is address some of the remaining questions by commenting, if that's okay.
Perfect. No, that's great. Thank you so much for your time. And here's a website where you'll be able to find archives of this probably in the next couple of days. And here are email addresses if you have any questions. And just want to thank the three of you for attending this afternoon, and hope you have a great rest of the afternoon. And thank you everybody who was able to join us.
Thank you for inviting us.
Thank you, everyone. Great questions.
Yes, very good. Thank you so much.